This lecture is concerned with care of the patient with a brain attack, which is also known as stroke. Now, just to review, we're going to look globally and discuss what parts of the brain actually do. So the frontal lobe, which is in red, is concerned with the ability to concentrate and attend, elaboration of thought, learning and behavior, including intellect, abstract reasoning, problem solving, judgment, sequencing, and planning. It controls emotions, expressive language, word associations, and memory for habits and motor activity. The parietal lobe, which is light blue, involves visual attention, touch perception, goal-directed voluntary movements, manipulation of objects, and is involved in the integration of different senses that allows for understanding of a single concept. The temporal lobe, which is in green, is responsible for hearing ability, memory acquisition, some visual perceptions, and visual memory. It also helps in the categorization of objects and the sense of identity, behavior and emotions, including fear and long-term memory. The occipital lobe, which is in gray, is responsible for vision. The brainstem, in light brown, controls breathing, heart rate, swallowing, reflexes, sweating, blood pressure, digestion, and temperature. And the cerebellum, in dark brown, is involved in regulation and coordination of movement, posture and balance, and some memory for reflexive motor acts. So you can see, if there is disruption in blood flow to the brain, the consequences depend upon where it happens. Now, the brain requires about 750 to 1,000 milliliters per minute of blood to supply oxygen and glucose. If that blood flow is interrupted, neurologic metabolism is altered in 30 seconds. It stops in 2 minutes, and cellular death occurs in 5 minutes. It's much like the heart. The brain is protected by a concept called cerebral autoregulation. It keeps the blood flow in the brain constant by changing the diameter of the blood vessels. The brain responds to increased CO2 by vasodilating and increasing blood flow. Also, very low levels of oxygen will increase cerebral blood flow. And this is important, and we're going to discuss it when we talk about head trauma. Factors that influence cerebral blood flow include systemic blood pressure, cardiac output, blood viscosity, and collateral circulation. Now, the term brain attack is increasingly being used to describe stroke. This term communicates the urgency of recognizing the clinical manifestations of a stroke and seeking emergency medical help, similar to that which would be done with a heart attack. Now, stroke kills about 130,000 Americans each year. That's 1 out of 20 deaths. On average, 1 American dies from a stroke every 4 minutes. Every year, more than 795,000 people in the United States have a stroke, and about 610,000 of these are first or new strokes. About 185,000 strokes, nearly 1 in 4, are people who have had a previous stroke. Now, about 87% of all strokes are ischemic strokes, and that's when blood flow to the brain is blocked. And it's very costly, about $34 billion a year, which includes the cost of healthcare services, medications, missed days of work, etc. And it is a leading cause of serious long-term disability. Stroke risk varies by race and ethnicity. Stroke is the fifth leading cause of death for Americans, but the risk of having a first stroke is nearly twice as high for blacks as for whites, and blacks are more likely to die following a stroke than are whites. The Hispanics' risk for stroke falls somewhere between that of blacks and whites. The American Indians, Alaskan Natives, and blacks are more likely to have a stroke than any of the other groups. Now, although stroke risk varies with age, strokes can and do occur at any age. In 2009, 34% of people hospitalized for stroke were younger than 65. So, what is a brain attack? It occurs when there is ischemia to a part of the brain that results in death of brain cells. Functions such as movement, sensation, or emotions that were controlled by the affected area of the brain are lost or impaired. And the most effective way to decrease the burden of stroke is through prevention. So we need to look at some risk factors. Now there are non-modifiable ones, which are being African American, age greater than 35, being a female, having a history of transient ischemic attacks, we're going to talk about them, stroke or heart attack, and even having sickle cell disease. Now there are modifiable risk factors. Those include the list below. I'm going to talk a little bit about them. Hypertension is the single most modifiable risk factor. It can be reduced by 50% if it's treated. Heart disease, in particular atrial fibrillation, is responsible for about 20% of all strokes. And if you remember from our heart lecture, that the clots that form in the atria during AFib are liable to throw a clot to the brain. Now, smoking doubles the risk of stroke. Excessive alcohol leads to hypertension. Obesity is associated with hypertension, diabetes, and lipid disorders, and they all result in increased risk of stroke. And then drug abuse, especially cocaine, causes vasoconstriction and leads to hypertension and subsequently to stroke. Now, sleep apnea, they think this increases the risk of stroke because of changes in blood flow during the apneic events. Studies show that blood flow through the arteries of the brain decreases during apnea, and this can correlate with the duration of the apneic event. Another possibility is that strokes are more common because sleep apnea exacerbates known risk factors for stroke, including high blood pressure, diabetes, and heart disease. Sleep apnea also causes inflammation in the body by promoting the release of stress hormones during the periods of apnea. This ultimately causes change in blood vessels and clotting, which may make strokes more likely. Now we need to look at transient ischemic attacks, and this is considered to be an episode of neurologic dysfunction caused by focal ischemia, but without infarction. Clinical symptoms typically last less than 1 hour. Now in the past, TIAs were defined as any neurodeficit that lasted less than 25 hours. But it has been shown that 30 to 50% of them show brain injury on an MRI. However, most TIAs resolve. The pathology may be related to microemboli. Whatever the cause, it's a warning that there is cerebral vascular disease. Now, there are two basic types of stroke. One is ischemic, and that has either thrombotic or embolic, and the other is hemorrhagic, including intracerebral and subarachnoid. We're going to look at both of them in depth. Now, with a thrombotic stroke, the thrombus occurs in relation to injury to a blood vessel wall and the formation of a blood clot. It is the most common cause of stroke. 2/3 are associated with hypertension and diabetes, and they're often preceded by a TIA. Embolic strokes occur when an embolus lodges in and occludes a cerebral artery. It is the second most common cause of stroke, and as we said before, a majority of the emboli originate on the inside layer of the heart with atrial fib. It's commonly a rapid occurrence and has severe clinical symptoms. The patient usually remains conscious, although they may have a headache. Now, hemorrhagic strokes account for about 15% of all strokes. They result from bleeding into the brain itself or into the subarachnoid space or ventricles. Intracerebral hemorrhage is bleeding within the brain caused by a rupture of a vessel. Hypertension is an important cause. Hemorrhage commonly occurs during periods of activity. Often a sudden onset of symptoms with progression over minutes to hours because of ongoing bleeding. Manifestations include neurologic deficits, headache, nausea, vomiting, decreased levels of consciousness, and hypertension. Now, with a subarachnoid hemorrhage, this occurs when there's intracranial bleeding into the cerebral spinal fluid-filled space between the arachnoid and the pia mater, commonly caused by rupture of a cerebral aneurysm, which may be saccular or variform. The majority of aneurysms are in the circle of Willis. And in this one, the indication is the patient complains of the worst headache of their life. Now, we need to look at an area affected by decreased blood flow to the brain called the penumbra. The penumbra is the area surrounding the ischemic event. Immediately following the event, blood flow, and therefore oxygen, is reduced, leading to hypoxia of the cells near the location of the original insult. This can lead to cell death and amplify the original damage from the infarction. However, the penumbra may remain viable for several hours after an ischemic event due to collateral arteries that supply that zone. As time elapses after the onset of stroke, the ability to save this penumbra decreases. Therefore, in the emergency department, a major concern is to protect that penumbra by increasing oxygen transport and delivery to the cells in that danger zone, therefore limiting cell death. The existence of a penumbra implies that salvage of the cells is possible, and there's a high correlation between the extent of spontaneous neurological recovery and the volume of the penumbra that escapes infarction. Therefore, saving it should improve the clinical outcome. So, what are the warning signs? A sudden weakness, paralysis, or numbness of the face, arm, or leg, especially on one side of the body. Sudden dimness or loss of vision in one or both eyes. Sudden loss of speech, confusion or difficulty speaking or understanding speech, unexplained sudden dizziness, unsteadiness, loss of balance or coordination, and sudden severe headache. So if someone's having one of these signs, don't ignore them. Call 911 and get medical help immediately. In general, if you have a stroke in your left brain, you get right hemiplegia, aphasia, intellectual impairment, slow, cautious behavior, and right visual defects. If you have a stroke on the right side of the brain, you get left hemiplegia, spatial perceptual difficulties. The patient may be distractible, show impulsive behavior, have poor judgment, may be unaware of their deficits, and have left visual deficits. Loss of postural stability is common after a stroke. The patient is unable to sit upright and tends to fall sideways. So you must provide appropriate support with pillows or cushions. Now, the clinical manifestations of stroke include impairment of mobility, respiratory function, swallowing and speech, gag reflex, and self-care abilities. Now, it's important to check that gag reflex, which, if you remember from health assessment, is controlled by cranial nerve 9, the glossopharyngeal. Characteristic motor defects include loss of skill, voluntary movement, impairment of integration of movements, alterations in muscle tone, and alterations in reflexes. An initial period of flaccidity may last from days to several weeks and is followed by spasticity of the muscles because of the interruption of upper motor neuron influence. Now, as far as communication goes, the patient may experience aphasia when a stroke damages the dominant hemisphere of the brain. Aphasia is a total loss of comprehension and use of language. Dysphagia refers to difficulty relating to the comprehension or use of language and is due to partial disruption or loss. And many patients also experience dysarthria, or a disturbance in the muscular control of speech. It affects the mechanics of speech, and impairments may involve pronunciation, articulation, and phonation. Patients who suffer a stroke may have difficulty controlling their emotions. They may be exaggerated and unpredictable. And they also are at risk of depression and because of their feelings associated with changes in body image and loss of function, and this can make it worse. Patients may also be very frustrated by mobility and communication problems. As far as intellectual function goes, both memory and judgment may be impaired as a result of stroke. There also may be spatial perceptual alterations, and some of these include an incorrect perception of self and illness. Patients may actually deny their own illness or their own body parts, and this is because of strokes that occur in the parietal lobe. They also may incorrectly evaluate their self in space. For example, they can't judge distances. They may have agnosia, or the inability to recognize objects by touch, sight, or hearing. Or they may have apraxia, meaning they cannot carry out learned sequential movements. So I want to tell you about the flow of a patient from the early identification of the stroke symptoms in through the ER. After you have identified that the patient may be having a possible stroke, of course, you call 911. and then the EMS does assessments and some actions. They obviously support airway, breathing, and circulation. They perform pre-hospital stroke assessment. They establish the time when the patient was last known to be normal. They do the transport, and it really should be to a stroke center. They alert the hospital, and they check glucose levels. So then they arrive at the door. And you again immediately assess ABCs and vital signs. You provide oxygen if hypoxemia. You get your IVs started and check the glucose again. You perform neurologic screenings, activate the stroke team, and then you have an emergency CT done and get a 12-lead EKG. Now you need an immediate neurologic assessment by the stroke team or some designee, and they review the history. And it's really important to establish the symptom onset, perform the neurologic examination with the NIH stroke scale, and we're going to look at that in a minute. But the biggest thing is, does that CT scan show any hemorrhage? Because that decides on the treatment. If there's no hemorrhage, you're going to check for if they can have fibrinolytic therapy, and you're going to repeat neurologic exam and see if there are any deficits that are improving or they're moving back to normal. If the patient remains that candidate for fibrinolytic therapy, then you're going to give the TPA, and you can't give any anticoagulants or antiplatelets for 24 hours. Now, if we go back up to, after they come back from CT, if they have a hemorrhage, you're going to have to consult the neuro team. And if you don't have one at your hospital, you're going to have to consider transferring them. In this case, you're obviously not going to administer aspirin, but you're going to begin the stroke pathway and admit to a stroke unit and monitor your BP, monitor your neurologic status, monitor your blood glucose, and initiate supportive therapy and treat any comorbidities. Now we're going to look at some of these diagnostics and treatment in a little more depth. CT scans help to distinguish between ischemic and hemorrhagic stroke, as we said before, and that the treatments are very different, so it is critical that that be done before you attempt to treat people. It also helps determine the size and location of the stroke. Angiography helps to visualize cerebral blood vessels, but however, this requires contrast and has risks including dislodging of an embolus, vasospasm, further hemorrhage, and allergic reactions to the contrast media. Transcranial Dopplers look at the velocity of the blood flow in the brain and is helpful in detecting microemboli and spasms. Now, all of those labs may help, but they are not specific to diagnosing strokes. So I want to look a little bit more at treatment. The goals for collaborative care during the acute phase are preserving life, preventing further brain damage, and reducing disability. Treatment differs according to the type of stroke and the changes as the patient progresses from the acute to the rehab phase. Elevated blood pressure is common immediately after a stroke, and it may be protective to maintain cerebral blood perfusions. You don't want to get aggressive in treating it. Fluid and electrolyte balance must be controlled carefully. The goal generally is to keep the patient adequately hydrated to promote perfusion and decrease further brain injury. Increased intracranial pressure is more likely with hemorrhagic stroke and usually occurs in the first 72 hours. And the problem with this is brainstem herniation, and we're going to be discussing that with traumatic brain injury in our lecture. Seizures can occur and are treated with anti-seizure medication. Now, recombinant tissue plasminogen activator, or TPA, is administered IV and used to establish blood flow through a blocked artery and prevent cell death in patients with the acute onset of ischemic stroke syndrome. Now, surgical interventions for stroke include the immediate evacuation of aneurysm-induced hematomas or cerebellar hematomas larger than 3 centimeters. For ischemic strokes, they may use a Mercy retriever, which allows physicians to go inside the blocked artery of patients who are experiencing ischemic strokes. The retriever goes to the artery that is blocked, directly to the site of the problem, and pulls the clot out. After the stroke has stabilized for 12 to 24 hours, collaborative care shifts from preserving life to lessening disability and obtaining optimal functioning. Now we need to talk a bit about nursing care of the patient with TPA. Now, TPA cannot be used for hemorrhagic strokes. This is critical. It should also not be used for those with major surgery, or if they've had an MI, or if they've experienced head trauma or acute trauma such as fractures, if they have a GI or urinary tract hemorrhage, or uncontrolled hypertension. Before TPA begins, you must get informed consent, and if you can think about it, that's going to be from some surrogate, such as the family member, because they probably would be considered as not competent. You also must place any Foley's, NG tubes, and IV catheters before the infusion begins, because it may induce bleeding afterwards. You want to run a set of coagulation studies and check their platelets, and of course be sure they had that CT scan done. During the process, the total dose is 0.9 milligrams per kilogram up to a maximum of 90 milligrams. 10% is given as a bolus, and the remainder is given over 60 minutes. Now, remember this. If there is acute hypertension, severe headache, or nausea and vomiting, intracerebral bleeding has occurred, and you need to stop that infusion immediately, contact a neuro team, and they'll go down for an emergent CT scan. After the infusion, they go to ICU for 24 hours, and the vital signs are done every 15 minutes for 2 hours, every 30 minutes for 6 hours, and every 60 minutes for 16 hours, and with each of those, neural assessments are done. Blood pressure is maintained less than 180 over 105, and you need to monitor for any signs and symptoms of bleeding. You cannot give antiplatelet or anticoagulants, and you can't do any arterial punctures, NG tube placement, or Foley placements. Now we need to consider hemorrhagic stroke. Drug therapy includes maintaining a blood pressure in the normal to high range, no TPA, no anticoagulants, no antiplatelets. You also must use seizure precautions for these people. Surgical therapy includes evacuations of hematomas, clipping of aneurysms, and coiling procedures. Now we're going to look at nursing interventions. As far as the respiratory status, there's an increased risk of atelectasis and pneumonia, especially aspiration pneumonia, because of dysphagia, difficulty with chewing and protecting their airway. All stroke patients must be assessed for ability to swallow and be kept NPO until dysphagia has been ruled out. The nurse must monitor vital signs, airway patency, oxygenation, provide suctioning as necessary, encourage mobility, encourage deep breathing. However, keep in mind that coughing with hemorrhagic stroke should be avoided because it causes an increase in intracranial pressure, which can be disastrous. As far as neuro goes, you're going to monitor the neural status using the NIH stroke scale. Now, this is a 15-item neurologic exam used to evaluate the effect of acute cerebral infarction on levels of consciousness, language, neglect, visual field loss, extraocular movement, motor strength, ataxia, dysarthria, and sensory loss. And a trained observer rates the patient's ability to answer questions and perform activities. Now, ratings for each of these items are scored, and 0 is considered normal. Now, I would know these scores. 0 is no stroke. 1 to 4 is minor stroke. 5 to 15 is moderate stroke. 15 to 20 is a moderately severe stroke. And 21 to 42 is a severe stroke. Now, as far as the cardiovascular system goes, it may be compromised if overhydrated. That can increase cerebral edema. It may be compromised if the patient is dehydrated, especially one who is at risk for vasospasm. The patient may be at risk for orthostatic hypotension, and it is important to assess before that first ambulation because it is a safety issue. And the patient may also be at risk for DVT. In regards to the musculoskeletal system, the goal is to prevent contractures and muscle atrophy by doing range of motion and proper positioning. Interventions include the trochanter roll at the hip to prevent external rotation of the hip, hand cones, arm supports such as slings, avoiding pulling on the patient by the arms because that can dislocate shoulders, leg and foot splints, and hand splints. And as usual, as far as the skin goes, you need to prevent decubitus ulcer formation. The most common GI problem is constipation, and as far as the urinary system goes, you may have to start a bladder retraining program, get rid of catheters, and if you're using an external catheter, be sure to monitor for bladder distension. And these are just pictures of the trochanter roll, the hand splints, and the leg and foot splints. Now, as far as nutrition goes, stroke patients need to be assessed by a speech therapist before feeding. You need to check for that intact gag reflex, and a swallow study should be done. Mouth care should be done before starting feeding because this stimulates the sensory awareness and salivation. Patients should be in a high Fowler's position, and food should be easy to swallow but have some texture. Liquids are just too thin to manage and usually requires the administration of thicket. You should avoid milk products because they tend to increase the viscosity of mucus and increase salivation. And you place the food on the unaffected side of the mouth. Now, it's going to be very important to consider how you communicate with a patient who has aphasia. First of all, you want to decrease the environmental stimuli so that you prevent distracting and disrupting the communication efforts. Please treat that patient as an adult. Present one thought at a time and keep your questions simple, such as yes or no. Let that person speak, don't interrupt them, and allow time for the individual to complete their thoughts. Gestures or demonstration is an acceptable alternative form of communication. And don't pretend to understand if you don't. Just say you don't understand and encourage nonverbal communication. Speak with a normal volume and tone, and give that patient time to process information and generate a response. Allow body contact because that touching may be the only way the patient can express feelings. And organize that patient's day by preparing and following a schedule. And don't push communication if the person is tired or upset, because aphasia worsens with fatigue and anxiety. Now, as far as transferring goes, in the first place, you want to place a chair parallel to the bed on the unaffected side. You want to make sure that the bed height is set at its lowest setting, and then you grab the patient under the arms, and the patient's knee should be between your legs. Then you have the patient put their unaffected hand on the side of the wheelchair. Keep your knees bent and then pivot them to sit. And that's so you protect yourself from injury and the patient from being injured. Now, there may be spatial and perceptual deficits in stroke, as we've talked about. Perception of a patient with homonymous hemansopsia will have problems with food that may be on the left side, which is seen and thus ignored. So, if they have this problem, you should arrange the food on the right side or left side, depending on which side is affected in the patient. It is similar to neglect syndrome, and they're at high risk of injury, so you need to closely observe them. You need to lower the bed, and if possible, have video monitors. Other problems, they may have diplopia, which is treated with an eye patch, and a lack of corneal reflex, which may necessitate the use of artificial tears. Now, as far as nursing diagnoses goes, the one that I want you to think about is ineffective coping. The nursing diagnosis I want you to think about is ineffective coping, and it might be related to situational crises, vulnerability, and cognitive perceptual changes such as stroke. And it's evidenced by inappropriate use of defense mechanisms. And what you want them to do is to verbalize acceptance of themselves. Some of the interventions include to determine their functional independence using a validated tool. You also identify the meaning of this loss for that patient. Some patients accept and manage alter function effectively with little adjustment, where others have considerable difficulty recognizing and adjusting to deficits. You want to determine if there are outside stressors, such as family, work, or social influences. This will help you identify specific needs and provides an opportunity to offer information and support and begin problem solving. You also want to consider social factors in addition to functional loss, because it's important in determining appropriate discharge destinations. You also want to determine if the patient is recognizing and beginning to deal with the stroke. Note whether the patient refers to the affected side as it, or denies the affected side and says it's dead. This suggests rejection of the body part and negative feelings about the body image and abilities, indicating the need for intervention and emotional support. You should acknowledge a statement of feelings about body betrayal, but remain matter of fact about it. And remind them that they can still use the unaffected side and eventually learn to control the affected side. Use words such as weak, affected, right or left instead of bad. And that is incorporating that side as part of that whole body, and it helps the patient see that the nurse accepts both sides as part of the whole individual. It allows the patient to feel hopeful and begin to accept the current situation. You want to determine the presence and quality of support system. You want to emphasize small gains, either in recovery of function or independence, and support behaviors such as increased interest and participation in rehab activities. You want to suggest possible adaptation to changes and understanding about their role in their future lifestyle. Most important, you want to monitor for sleep disturbance because that may indicate the onset of depression, which may require further evaluation and intervention. I want to talk a little bit about stroke rehabilitation. Rehabilitation is the process of maximizing the patient's capabilities and resources to promote optimal functioning related to physical, mental, and social well-being. Regardless of the care setting, ongoing rehab is essential to the patient's abilities. Rehab requires a team approach, and the goals for rehab of the patient with stroke are mutually set by the patient, family, nurse, and other members of the team. The nurse initially emphasizes the musculoskeletal function of eating, toileting, and walking for the rehab of the patient. After the acute phase, the dietitian can assist in determining the appropriate daily caloric intake based on the patient's size, weight, and activity level. A bowel management program is implemented for problems with bowel control, constipation, or incontinence. Patients who have had a stroke frequently have those perceptual deficits. For example, patients with a stroke on the right side of the brain usually have difficulty in judging position, distance, and rate of movement. Remember that the patient with stroke may experience many losses, including sensory, intellectual, communication, functional, role behavior, emotional, social, and vocational. And nurses should help patients and families cope with these losses. Speech, comprehension, and language deficits are the most difficult problems for the patient and family, and speech therapists can assess and formulate a plan of care to support communication. So, as you can see, it really does take a team to care for these patients. Now, the three major goals of rehabilitation are to prevent complications of prolonged inactivity, and to decrease recurrent stroke through exercise. And that regulates body weight, fat stores, blood pressure, glucose levels, and the total level of blood cholesterol. And it's been revealed that it creates changes favorable to vascular wall function and promotes plaque stability. It also increases aerobic fitness, which increases oxygen uptake. Now, as far as prevention goes, you obviously need regular medical checkups where they assess for risk factors. Maybe think about daily aspirin and cholesterol meds. Please quit smoking, any of you that do. You want to make sure that your diabetes is controlled and maintaining a healthy weight. Do some kind of exercise decrease your alcohol consumption, and stop taking birth control pills and use an alternative form. This is really important if you have several of the above risk factors. Now, early diagnosis and treatment will determine the patient's outcome and restoration to health. And part of the Healthy People campaign goals include those who are uninsured because they're at greater risk for disability due to lack of access to care, and they delay treatment. However, the good news is research shows that stroke patients that increase their cardiovascular fitness can achieve pre-stroke endurance and independence. And this ends the brain attack lecture.